Hello, good evening. Welcome from Aster CMI Hospital. I'd like to introduce Dr. Raghavendra. He's our lead consultant for pain and palliative care. Sir has a background of anesthesia, chronic pain, interventional pain, and then he's gone on to do palliative medicine. And it becomes a vast array of ways in which Sir can support, and hence great importance for our topic today. I'm Dr. Amelia. I work with Sir. I am a palliative physician, and we both are consultants here at Aster CMI Hospital. So, without further ado, I want to invite you all for today's topic. So, why are we here today? We are here today to celebrate World Hospice and Palliative Care Day. I'll just give you a very short introduction, very brief introduction. World Hospice and Palliative Care Day, this is the 19th time that we're doing it. We've done it for 19 years. It was actually organized by the Worldwide Hospice Palliative Care Alliance. It's a charitable organization. And what they have done is they've got everybody globally to try and champion for palliative care. So different countries face different challenges and they have found different solutions. So putting together so that each one of us can actually benefit from the other's experience has been their goal. In general, palliative care, if you look at it, it is still an unmet need, though we've come a very long way. And the current status, actually, when determined by the World Health Organization, says that only 12% of global people have access to palliative care. So there's more than 18 million who suffer with pain and distress. So palliative care has become a very deep necessity for everybody to have an understanding about and to be able to know what their role is. So we come then to today's topic. So this year, what World Hospice and Palliative Care Day, the theme they have chosen is called Compassionate Communities Working Together for Palliative Care. So it's very apt because we have first said that World Hospice and Palliative Care Day has taken experience from all over the world.
Absolutely.
And then they have broken it down to saying, though we are trying to find everything around the world, we now have to work together as communities where we are in order to be able to provide palliative care.
At the community level.
At the community level. Because everybody thinks, oh, palliative care is something in hospital.
Or hospice.
On hospice. So the topic was compassionate communities. So we were thinking, what is it? Why did they choose that? So compassion, actually, as defined in the dictionary, says that it is a strong feeling of empathy for people who are suffering and a desire to help them. So I think the emphasis is on desire.
Desire and to help.
To help. So in a community, to actually make a healthy community.
Absolutely.
I think when palliation is spoken about, everybody thinks it's cancer. But could you talk to us, sir, about actually if you're to be a community that helps to make health, to make everybody be able to achieve a quality and dignity in life, then what else are we looking at in palliative care?
So, welcome you all. The reason why we are celebrating this day, World Hospice and Palliative Care Day, is mainly to build awareness and to get like-minded people together to work, to champion, not only in a hospital or in a hospice. The hospice is a connotation which is actually might not be suitable to our Indian community or Indian context, because most of us would believe in actually taking care of the elderly. It could be taking care of our children in whatever sense. But when we actually taking care and match palliation, so what is palliative care about? It's about dealing with any of the concerns of a person who's got a terminal illness. It could be end-stage renal, end-stage cardiac, end-stage pulmonary, like COPD it could be, or it could be dialysis patient, it could be cardiac patient who's coming visiting the hospital multiple times. It might be anything which is related to the liver. So it all encompasses anybody. It could be any disease, any age group, as well as oncology is something which most of them actually relate to palliation, but this is the actually broadened spectrum. And once you are in the community and you have a long-standing illness, just oncology has got a defined or a finite time, whereas the others have got a indefinitive. It could be managed well and it could go on for years. And this is where somebody would require a lot of support from the community.
So we were actually having a I was having a conversation with a professor of mine a couple of days ago, and she had cared for her mother who had no illness. She was not a diabetic, she was not a hypertensive, she didn't have any heart issues, but she saw her mother gradually declining and depending on her more and more. But she was a full-time working doctor, so it became very difficult to manage on her own. And it was the support that she got that was important. So when we are talking about community, so community again, the definition is sharing or having certain attitudes and interests that are in common. So you have a community. So when we talk about community in your mind, if we are saying in India we have to have a community, why is it different in India, a community, than in a Western culture? Because many people think, oh, palliation, more Western. It was developed there it is proper, here, where is it available? What's the difference in community involvement in caring?
And actually, the community could be at various levels. It could be a club membership to going up to every aspect of my neighbor who are in the neighborhood surroundings and things. So it could be, as you mentioned, who are having the common interest. The common interest, if it's there, then the community starts there. So the well-being of the entire people who belong to that community is what is most important over here. And we will have people going through various concerns, issues at various parts or time frames. So over here, in an Indian context, compared to Western context, the abandonment of their loved one at any point of time is something which is considered socially unacceptable. And that feeling of saying that I have to take care of my loved one, it could be older people, it could be any of them, is very, very deep-rooted. And that deep-rooted ethos will require this. And it is very, very apt saying that it's just not a community, one person, which is actually becoming more and more westernized now. As we are actually moving towards a nuclear family, we will require a lot of these kind of supportive initiatives in the community level itself so that they could get that. And everything cannot be taken up in terms of a doctor or a nurse or a healthcare professional who could deliver. There are certain multiple things, multiple issues and concerns a patient as well as the family members would go through during a chronic illness or a chronic disease of a life-limiting stature or that kind of problem wherein they need a lot of support. The support could be of various types. It could be simple calling up people. It could be connecting people. It could be in terms of actually making certain arrangements, driving somebody to the hospital, fixing up appointments. It could be in terms of, I might not be physically present. Could I do certain other aspects to your kith and kin? Or taking care of somebody who's there at home when the other person is actually shifted to the hospital. These are certain things which could go a long way in helping a person going through a concern. Whereas even the patient themselves will feel more or less burdened that if a single person is actually running a house and that person has to run around for everything and you get small amount of help itself, that could also become a less burden on the patient themselves, saying that they're less burdening the loved one who's actually taking care completely alone.
So because community, actually nowadays we have a lot of flats, we have a lot of these places coming up. So you have unions within there, you have people who are working together to have functions and things. So like a group could be made where these people are requiring help, can you help? That actually goes a long way.
Correct.
So there is a inhibition, isn't it? Though,
absolutely.
Where you think, should I interfere in somebody's life? What should I say?
So the first important thing is, are the people ready to divulge the diagnosis and tell I've got a life-limiting illness? Some of them might not be, unless and until you're very, very close. So building this tight communities are very, very important. That's exactly what we go back to the sentence or the definition you mentioned is like-minded, a common goal. These thoughts, if they're together, obviously, if somebody is there to offer also, acceptance also becomes a big barrier. So therefore, first of all, we should create a community of like-minded people. There should be a concern that this would work for that cause. This is made aware and public, and then it's accepted also.
Accepted. That's the way forward. And it's Not always easy to build these communities, not always easy to have the acceptance of this community. I think there is a human nature. Why are they doing it? What is it in for them? Privacy that people want to maintain. But then when you respectfully do it, I think in a period of time it would make a difference. And I think that's the goal of this talk of World Hospice and Palliative Care Day. It's not that today you go and tomorrow you have a community, but you be consistent and you build it up and it works. So quality of life. So you and me, now we are palliative physicians. So a lot of people feel that there is only a specialist palliative person. But there are different ways in which to provide palliation, isn't it? So could you just guide us, tell us as to what other ways in which palliation can be provided and what is community-based palliative care?
In terms of palliation, what happens in a hospital setup like us is more of acute palliative care unit model, wherein there is a concern which is actually really pressing and they need an immediate look into, and a medical management which is very, very important at that point of time to make or tide over a crisis at that point of time. Palliation itself is tied over a crisis, but at that point of time. Now, that is kind of a medical concern or an issue or a physical concern which cannot wait. But if you have a planning, you have acceptance, once the plan has been made, once the acceptance is made, and we know who is there to support each other in the community. That is, could be a group of people like these, or if there is an eventuality, if there is any concern which happens, now getting them back to the hospital or working with them in various aspects will all be forming the community itself. Now, specialist palliative care work in a specialist center, whereas in the community, it could be all the people around, plus you could have healthcare professionals also, trained healthcare professionals who could be there at their residence itself, which is much, much more acceptable. What I mean is, in India, taking care of their loved one at home is much more acceptable socially rather than putting them into some other center, is what we have actually found in our studies also. And that is where the community also would be more happy and they would be more empathetic. They're taking care of their loved one at home. Let me help them out. Or this is what I can actually be teaching my own kith and kin. Or indirectly, they would look at this and they would actually also learn. This is where the generation would actually take it ahead. I think empathy to emphasize within getting it recruited into the community is more better and apt if we are able to follow these. Now, in the community, we could have the doctor, we could have the general practitioner, we could have the nurse and other things who could help with various aspects on a day-to-day basis. But if the concerns are there, then they would come back to a specialist center.
So that brings me to us to the point when you said community-based palliative care, we work on a concept of pain and patients who are in life-limiting illness going through something called as total pain, correct, sir? So based on the community support that can be provided, how does total pain and the community support, how can it be supported?
Now, if it could be physical aspects itself. So if you have some medications which have been prescribed by us, somebody could even actually look into how they could be positioned properly, massage them, take care in terms of sitting, talking to them, socializing with them, getting them to actually have an individual way of de-stressing them, debriefing them, or it could be in terms of spiritual concerns, issues. If somebody is ready to talk to them, at least listen to them. Active listening itself could be the biggest palliation a person would require.
What's active listening?
So active listening is somebody should be actually left in a space where they are felt saying that my concerns, issues are somebody is there to take care. If somebody is actively listening to them and trying to reciprocate what they're talking about and then tell what best could be done from their aspect or what could be suggested. In that sense, I think that could be more of an active listening.
So it's not about us actually telling them what to do. Sometimes you just want somebody to listen to you, isn't it? Not to be there to judge, not to be there to give ideas all the time because you've done everything. And I think that is
rather than there, not to be judgmental.
Yes. Yeah, because sometimes you think, oh, you've got cancer of the lung, you smoked, then you deserve this.
Yes.
Because that's a common thought. But then not everybody who has lung cancer has been a smoker. So
Absolutely.
it's something that is a myth or a thought in the community. So education in the community as to how maybe we can handle them. Education in the community with volunteers who are willing to support, but to help them understand what active listening is and that it is absolutely fine to be in silence.
Correct.
You don't have, when you're talking with somebody, you don't have to fill every moment with a word. You could just sit there, you could just listen, and the person will start talking. And it takes some time for anybody to trust anybody.
Absolutely.
It just because
it can't be of the first meeting itself.
So you've got to be persistent, and as you said, that empathetic, persistent nature, saying, I want to help. That compassion, if it is not there, you will try once or twice and then you give up.
The body language itself could be a lot more there. Yes. Active listening starts from inner body language to what you're doing and things. Nodding could be and being there. And once they have actually put across a question, could be in the plane of the sentences, rather being judgmental, saying that whatever is important is something which me also would be doing the same. So from the total pain concept which you just mentioned, physical concept, psychological concept, spiritual and social, all these things are there. Now, economical is a bigger, tighter concern. But there are a lot of people who actually make communities which could support in that sense also, if it is possible. And yes, there are a lot of people who actually vouch for it. And absolutely, if it's possible, yes. So in all these senses, we could burden them to least possible, whatever we can. That's the best for that person.
And when you're at home in the community, a lot of time where you mentioned, there is the studies that have been done in Indian soil and internationally, where anybody with a life-limiting illness, though it is prolonged, heart failure, at some point they are going to come down. Chronic obstructive lung disease, where there are long-term oxygen, at some time they're going to get too breathless. Everybody will come to a point where it's called end of life. So where is this end of life part in a person's life, in a life-limiting illness?
So it could be an active deterioration, we know, saying that any form of disease management starts becoming to burden them more rather than benefit them. So that is where, saying that it is more of end of life care, wherein you've had a discussion, you've told the people who are all concerned with that loved one that this is not a disease which is going to be treated. It is more in terms of supportive and symptom control, which is the best possible over here. And mind it, if you do these two things properly, you're going to make them live actively as much as possible. And quality of life and dignity of life is definitely improved. There is no doubt about it. But if palliative care principles are applied meticulously and taken care, they would improve their longevity of life also. And it's just not applicable to oncology, as I'm repeatedly mentioning, because the connotation is oncology all the time. So therefore, we should actually think about any age group, any context, any life-limiting illness is something which needs to be taken care. And active dying is what is a context which happens only in the last 72 hours, wherein your supportive care, like active fluid rehydration, others are all reduced, and the person is just there, and his pulses are weak. He's actually trying to be, in any sense, only symptoms matter at that point of time where he's deteriorating. I think the end of life care is inevitable at that point of time, as active dying is what we can phrase it as.
So when a community comes together, when they know, let's say I live in a flat and I know somebody's loved one is actually actively dying, though we are not able to support the patient as much as a community, because then it becomes a doctor's role to manage the symptom, there are what we always say as pharmacological and non-pharmacological. So as a specialist palliative team, we would have taught the family how to do non-pharmacological. And the caregiver then lack of sleep, not eating properly, not drinking properly. So the community steps in here and says to the caregiver, I'm with you. And you can take turns to actually sit with them while they're waiting for a very painful time. And that is important.
So just giving them a break for about 4 hours
makes a big
difference in daily life, and they would be able to actually rest for a while, or go have a nap, or
just a
shower, or even just go for and sit for some time and pray. These are certain aspects which are very, very important for a person to actually get back their zeal, get back to them to life, jump back on a daily basis and take it ahead. So that's where we are.
There is a at the end of life there or any time when patients are not doing well. The question is, it's all well and good you both sitting here and talking about it. We are in the community. So it's like there is a big abyss, there is a big gap.
Yeah.
But there is a way we are trying to bridge that
Correct.
gap. So could we understand from Aster Hospital how we are trying to bridge this gap?
So we've launched something called as Aster Care Extended. That's where we actually go home in terms of actually doing teleconsults, not to shift the patient much, exactly whenever it's really, really interactable. That is, some symptoms are really, really bothering them, despite our best of our efforts over the phone, over the video consultation, over guiding the caregivers, as well as the healthcare professionals within the community. If they're not able to manage, they're coming back. But in our context, we have seen saying this could be a very small number, large number will be there at home. And these are the ones who will need a lot of support from their local community. And these local communities are ones which they get awareness better, they get to understand what they have to do, what is the line of management plan, and how they can actually help, and what is acceptable by the patient as well as their family members. Once they get into that, definitely it's going to be much, much better. Now, why we're building this awareness is, if there is a concern, there should be acceptance from the people also and reach out for help. At the same time, there should be somebody who's ready to help them also. And if this starts at an earlier stage, whenever there is a life-limiting illness has been put across to the patients and the family, could be some time, and they are accepting the community in, it goes a long way, especially in the tough phases, in the quite end phases, what we just spoke about, a real critical time wherein an eventuality is expected. At that point of time, the community can stand strong with them, as well as the person who's actually leaving the legacy back. They also will feel saying that there is somebody to actually support these.
That's bereavement, isn't it?
That's later on.
Later on, yes.
So that's also there, somebody who's going to be supportive. So for us in palliation, it's as important as when they're no more. So therefore, it becomes a continuum
Very
of care.
important.
Yeah.
Because even from palliative, whether we doctors, whatever we learn as well, what the community, what the patients have and the relatives have always told us is, if you are not there to help us when my life was tough, when I was facing the most difficult situation in my life, once I have lost somebody, coming and crying and then telling, I'm here for you, has actually no value.
Yes.
So if as a community we are there to support one another when things are tough, then when the loved one has passed on, the family or the unit that is left behind that's devastated, it's more easily acceptable to have your help then rather than when you are not helping.
Absolutely.
We are talking just of a community, let's say we are in Sakar Nagar, we are going to build a community here. But then that's not sufficient, isn't it? So World Hospice and Palliative Care, their vision and should be like our vision, where they say building a community which is local goes on to build
a good city.
The
local communities,
city.
Local communities make the full city, compassionate city. The city gets on to the district goes on to the state and the nation ahead. So unless and until we don't start from the smallest possible link, we cannot build a larger.
And we are the smallest possible link. Every individual is the smallest possible link, isn't it? And it also actually goes in, the studies have shown that actually by 2050, our aged population is going to be very, very large. And you and me are going to be part of that population.
So that's the individual context over here when we're talking about. That is our thought saying that somebody is there for everybody, inclusive of us, at that point of time.
Isn't it? So in a community, actually, if we talk about it, it's not just us. The way we look after our colleagues, the way we look after our neighbors and our community, our children are watching us.
Absolutely.
And if we don't do what is right by everybody around, there's so much war and so much hatred around. And if we don't build a community filled with compassion and love, then it's not going to be a very nice future for our children. Isn't it? So nuclear family, we were extended. We had 10 people under one roof. We've come to 4 or now 3. But if each one doesn't support, it becomes difficult.
Absolutely.
So from Aster Care Extended, how can the community reach out to us, or how can we from Aster support communities out there by education, or how can we let them know that we are there to help?
So if they have concerns and issues, if they reach out to us, we have a coordinator who would be able to look into the specific concerns of a loved one, their patient, anybody, whatever it is. Now, we will try to reach out to them and we will be able to do teleconsults, get the patient to understand what it is, what is there, what could be done better now with the ongoing symptom burden or any of the other concerns which the patient has got. Caregiver going through a lot of psychological concerns, issues, burnout, the most common which we see when they're taking care of a loved one who's going through a chronic ailment. We would be able to handle them as a team. We've got a lot of people in our team, like nutrition, it could be in terms of physiotherapy, occupational therapy, and others, which are very, very important and issues. Now, how to actually make them sit in a bed, how to move them out of the bed, or how to take care of a bed-bound patient. These are certain things which we will be able to actually give a detailed knowledge, and they would be able to take this ahead. They would be able to take care. Now, once they have concerns, once they are taking care and they have again an issue or a concern, they can get back to us. This is where we would not like to abandon anybody who would reach out to us. I think our motto is we will take care, and that is important for all of us. So ACE is something which we are committed to, and we will take this commitment ahead. Now, we would be very happy if anybody who would actually in their own communities also would like us to go there and actually talk to that community itself to bring about awareness. So we have got a lot of corporate responsibilities which we go do a lot of talks. It could be at community level, that is the neighborhood, whatever the contact which we do, we can go and talk to them also and bring them all together. And if there are concerns and issues, how to go about, how to offer, how to take it ahead, and what is the other things which are required, I think we will be able to get the awareness building, all of that done.
So contacting us is the first step.
Absolutely.
And our phones are usually on 24/7. And we've never actually said no to anybody
who's in need.
out.
Yes, absolutely.
To reach out to us. So I think if we can summarize in what we have been speaking, the reason for today is World Hospice and Palliative Care Day. Internationally, different places are celebrating this day.
Absolutely.
And bringing about awareness of palliation. And this year, it is about encouraging people, the common person, every individual to be responsible for the community in which they are, that everybody needs help. One day I'll need help, one day you need help. So if we help each other, that's the way forward.
Absolutely.
And in the context of palliative care, it is not only at the end of life.
It starts with diagnosis of any life-limiting illness. And it's not only limited to oncology. So dementia, Alzheimer's, Parkinson's, there are so many life-limiting illnesses because most of them are able to be controlled by communicable diseases are because of vaccination and other improvement in healthcare. But non-communicable are something which is going to be the next problem or chronic issues and concerns which will take over the world.
Because dialysis, let's just take dialysis for that matter. Some people are on 2 times. If we could just take the burden off them for a day and ensure that the patient has the dialysis and taken home,